Hey, welcome in class. This is Annalise. This is going to be a conversation about substance use disorder and substance use in general. So hopefully you find, use in this video. I believe it'll be about 20 minutes, so throw it on YouTube in your car, what have you. And let's get started. So here we have the actual substance use disorder criteria from the DSM and talking about what are the different things we're going to be looking for. So number one, impaired control over substance use. So consuming the substance in larger amounts, persistent desire to regulate or to reduce and having issues with doing that, spending a greater time with recovering or using the substance, and experiencing cravings for the substance. Number two, social impairment. So this right here is going to be where you're having the social relationship. So fulfilling major obligations at work, significant social interpersonal problems. So this could be in the relationships with their family, with isolating themselves to engage in substances, reducing of discontinuation of recreational, social, occupational activities. So the continuation of DSM is going to be the risky use and pharmacologic. So risky use is using it in risky environments or dangerous environments physically. And then also the persistent use despite the knowledge. And I find that this is interesting because part of the prevention or harm reduction or empowerment with substance use disorder is actually getting the information of how can this be harmful to you and your body or your mind. So yeah, just an interesting mix there because people can still continue to use despite having this knowledge. Pharmacologic is tolerance and withdrawal. So tolerance is increasing tolerance over time, and then withdrawal having issues with withdrawal. And it has us know about blood issues, tissue levels, substance decrease. This, we're not going to be running those tests specifically ourselves. We may work alongside with people who do. But yeah, having this knowledge important for the criteria. Tolerance and withdrawal of the context of appropriate medical treatment. So pain medications are not count as criteria for substance use disorder when taken as prescribed. Noticing the substance use disorder in general, but also the specific types of substance use disorders are going to be helpful for you to read up on and reflect if your client is engaging in any of these substances or multiple. Right, and we have alcohol, cocaine, cannabis, tobacco, methamphetamine, opioid use. So something to note here, which is in the last slide, there's been no withdrawal unlike from MDMA substances. Can it still be an issue for somebody though, where they are, engaging more so and avoiding their day-to-day life tasks? Sure. But there's not that withdrawal aspect. So another important part right here is, right, tobacco versus alcohol, for example, both legal, but both can have social implications where it's a social aspect to engage in these, but it could be more hindrance if somebody's severe alcohol use versus severe tobacco use. And I'm just reiterating these things to start the conversation. But noticing like somebody may meet criteria, but it may not be their focus, right? For the example, like tobacco use disorder, that may not be their focus in therapy. So here I have medication names. This is going to be the slide where I believe in the emails y'all had sent back and for wanting to know more information about medication names, generic versus and drug types and psychiatric medications. So I did include that in the slide. That's not the main focus of this lecture. Rather, it's about the nuances of substance use. So, and it would just take a lot of time to go through every single type of medication. So how can you empower yourself in learning these things? For one, I encourage you to get curious in general, but also, reading up things as you go along and asking, your clients, oh, okay, you're having this medication, and reading up on it to know, okay, this might be a side effect for them. This may be something to look out for. And it can be helpful, especially for clients that need a lot of advocacy or you work alongside with a targeted case manager. or a case manager, because somebody may need support in advocating for themselves regarding medication alterations or updating them. And then again, for the drug use, drug types, that's the third one here on the slide. That's this one right here, which is right the different types of substances that you're going to be seeing that could potentially be, used to meet criteria for that substance use disorder. So psychoeducation is one of the ways that we're going to be looking to support the client in substance use disorder. So if it's minor use or if it's frequent use, major use, this could be an important conversation for your clients. So especially if it's major use, or if clients have questions about it, this can be a great way to support your client. So it can be as simple as giving them an image, or having some main talking points of how does alcohol affect the body, right? We have more known things like the liver, and something like the mental health, and talking about that more in depth, because of your scope of practice. But also just being able to talk about these things and then process with the client, what is this like to actually process this information, and how does that, affect you in your choice of using substances or not, or alcohol specifically. Something may less known may be, metabolism, musculoskeletal system, immune system. Whereas, it just may not be known. So this is the information where we can provide the clients and then support them in processing that information. Again, here is the effects of cannabis, and so we'll talk about it a little bit later, but the social implications of understanding cannabis. Sometimes people are going to be very pro or very against cannabis use. And it's an interesting conversation to have for sure, and understanding where the client's coming from, maybe where their perspective is on it, to be able to navigate the conversation. So that way it's not just you as a professional saying, hey, you need to stop this because of these problems, or saying, oh, it's no big deal because of these problems, and the client saying the opposite, right? And that in turn damages the rapport. So example here could be another image of common short-term effects. So dizziness, dry mouth, nausea, sleepiness, increased heart rate. That's an interesting combination there. But more long-term, especially with predispositions for somebody, delusions, hallucinations, psychosis. And then here on the left side, we have different levels of confidence of effects from cannabis, which are high addiction to marijuana and other substances, and then medium for schizophrenia, then for low is lung cancer. So seeing these different risks and the short-term versus long-term effects for this, and so empowering the client allows them to make that decision a little bit with more clarity, and be informed. So the substance use assessments are going to be really helpful for you if you're curious or you're unsure of where to kind of go with your client. If it's not the main part, I know for some facilities it's just part of the intake. So it could be a question of, hey, I'm just curious about the use, especially if it's not, number one, if it's not coming up as naturally, or you're have some information but the client's not really giving you enough. These can be really helpful. I find that mental health assessments are really helpful for clients too, to be able to name their experience. So for example, right, we're not going through the DSM with the clients, but some people may find it really useful to say, you know what, I want to focus on reducing my symptoms related to social issues. And then I want to focus on the issues related to, right, social impairment versus the withdrawal aspect. Like I want to focus on these specific symptoms. So mental health assessments are an easy, accessible way for clients to be able to name their experience. And that's overall, but especially in substance use. Here is a great graphic. The link is, at the end with the references, but if you go into the slide, it's also in the notes. So you just click on notes for this slide. But anyhow, so this is a great chart because you're able to see, okay, what are these different substance use assessments for? There's so many. So if you have somebody with alcohol use versus drug use, adults, adults versus adolescents, and then self-administered versus clinician administered. So this can be really helpful insight to know, how which one to go for your client. The intake versus the ongoing conversation. This is where we're talking about an ongoing aspect. Now, something I want you to keep in mind as a clinician, as a newer clinician, is that when decisions are being made about, if the client needs to have a more information or needs to have a referral maybe, these are not going to be overnight conversations or just independent of yourself. These are very collaborative conversations. So number one, knowing the use and the frequency, right? That mental health assessment, you may administer that and know, oh, okay, this is more than I thought, or this is less than I thought, whatever. Knowing the frequency can help you point in the direction of how much it's being depended upon and what are the implications for the client. Creating a safe space for exploration. So I know for some clients that we've talked about in supervision, are the that may not be the exact use that the client is actually, or the exact problem that the client is actually wanting to focus on. But we're seeing some themes of, okay, this isn't the exact problem that you brought in, but there seem to have some themes going on, such as avoidance of anxiety. So then you want to get curious about, okay, so if we're avoidance of anxiety, maybe we need to have more distress tolerance skills. So for example, this may look like noticing, okay, we have the curiosity of saying substance use is used for this particular aspect. Maybe we want to add in the different tools on the tool belt and not just saying we need to remove this tool and throw it away. We just need to add to it, and naturally becomes, less frequent because we have more tools in the tool belt. This is interesting, especially when somebody is like a little bit younger and they're starting their jobs. Is it going to create a problem for them uh, when they get into the workforce because there's anxiety or because there's a decreased use in substances, or is it going to benefit them to have that different structure? So getting curious about it with the client, just on multiple levels, is helpful. This and another example from Dr. Dunn that her and I talked about, which is somebody who has trauma, PTSD, and then they also have criteria for alcohol use disorder. And that becomes really, really a great risk. So noticing the co-occurring aspects and how they create risk for one another. So if there's only this one type of coping mechanism, what work can we actually do? And so the developing of the distress tolerances, if somebody is constantly right high or drunk, or under the influence in any capacity, what work can we actually do? It's not going to happen. If somebody is unwilling to work on the different distress tolerance skills and they've maybe minimized their experience in substance use, it may be a time to explore and say, hey, I'm noticing this pattern of avoiding this conversation, or anytime I bring up this aspect, this anxiety or this substance use, there's a defensiveness. And so getting, again, curious about what is the defensiveness coming from, and is there more of an avoidance aspect, or covering up, versus going and being more open about it with you as a clinician. So for a referral, again, this is not going to happen just as like a quick conversation. For some clients, I think for many of the Regis clients, it's appropriate to have ongoing conversation of like, is this necessary? Is somebody is seriously considering, um, and wanting to stop a substance. And right, that's one of the criteria for substance use disorder is wanting to stop and not being able to or having difficulty with it. Then that can be, of course, conversation with the client about, okay, well, this is the specific avenue to take for that and the specific clinicians to seek out or the specific um, facilities to be referred to. Um, uh, so more glaring aspect is going to be the inpatient aspect right here, which is detox severity. That's going to be decided by the site to say, yeah, this is a severe detox, and it needs to be under medical supervision. And one that comes to mind is going to be alcohol. That one is deadly for detox. People can die when coming off of it. Um, and another aspect is the severe discomfort, right? Um, Inpatient is interesting as well. An interesting conversation for the co-occurring aspect because where I had worked, I'll just share with you all, for my inpatient work, we had a detox unit and the clients there was detox slash low acuity. So if somebody had substance use as their primary, they could not room because there's two people to a room. They could not room with somebody who had mental health as their primary, and that is interesting because they're both lower acuity where there's not as much physical risk or severe suicide risk coming in. But because someone doesn't meet that criteria, they're not able to room together, and which affected census and ability to for insurances and whatnot. So this would cause them to look, or seek out somebody who was appropriate to room with them, so that way they're able to fill that space essentially. And yeah, interesting conversation and upsetting amongst the staff because substance use, there's rooted aspect in mental health, of course. So confusing for a lot of people. For emergency commitment, this is a law in Colorado. This is a short-term, quote, short-term because it's 5 days for involuntary hold for withdrawal or management detox. And from what I've seen working with individuals who've had an EC hold is basically first couple days is physiological, like addressing the basic needs, sleeping, eating, drinking water, just getting bearings in order, being able to detox. Um, and then after that, it's going to be more focused on the actual mental health aspect. Because if it was 3 days, um, from what I've seen is that there's no actual help happening. It's just not actual help, let me rephrase that. There's no mental health help, but there's more just physiological help, which is great. And right, there's limitations there. So with referral as well is going to be danger and dependency for the client, and collaborating with them, noticing, okay, maybe over time, first we've had clients say, okay, this is actually the help I want to talk about is the relationship. So we find out that the relationship is actually a symptom of the substance use, or the substance use is a symptom of the trauma. So we need to address that so that we were able to be safe, right, and not have that danger aspect. And talking about that scope, right? That could be in conversations with supervision to say, you know what, I'm actually not equipped to support this client because of this danger aspect, and I feel that they would be more helped in this capacity, right? So respect for the field and being able to say, yeah, there are actually places and individuals that are qualified in these things. Not to say that we're unqualified because we have this knowledge, but noticing maybe an avoidance to address it as well, right? So somebody may avoid that or may deny and minimize that because it's not an issue that somebody wants to focus on, right? If there's still that danger there still needs to be an addressing that issue there. We can't just ignore it because the client says they want to ignore it, of course. And for some instances, it genuinely is minimal, and they don't meet criteria for substance use disorder, and we're able to continue on. That may come into play because there's still that non-judgment aspect where someone's able to openly say, yeah, I've done this drug, once a year at a music festival or something like that, versus daily use that's getting in the way of their life. Can someone meet criteria for substance use disorder and have a co-occurring disorder? Yes. So again, as I mentioned before, that inpatient aspect, they try to kind of dichotomize it, and in reality, that's just not how it works. But can someone meet the criteria and still continue therapy with you? It depends on the risk. It depends on the level of issues that they're having. If it's more of a social aspect, being able to learn the different social skills, communication skills, learning distress tolerance skills. Is that person willing and able to do that, and they're showing effort in that? Now, if there's an impairment that comes into the therapy space, or if that's their only skill that they've ever used, there may be a need to address that first, right? Especially with these highly dangerous aspects of alcohol or other substances. Mental health focus, so getting, the substance use focus is going to be focusing on the physiological, social, and mental health implications of that drug, versus the mental health focus is going to be curious about the implications, limitations, benefit, and risks of that, and kind of how they're affected by it. So, for example, for clients where it's a question mark about how much their drug use is actually affecting them, you're able to explore that through the lens of possibly through the lens of substance use disorder. But if it's like a denial, right, being able to assess out in the moment and saying, if this is going to ruin the rapport with the client because they're denying it, and it genuinely seems like not a risk, then it's okay to move forward. Especially if it comes up a lot, though, we might be curious about pointing to the substance use disorder to say, hey, you actually meet criteria for this. Let's dive into this a little bit more. I'm thinking about some of your clients right now, which I won't put in here. But they may meet criteria, and this may be significant for them to understand and focus on. It may also be significant for them to learn the skills first, and like communication skills, distress tolerance skills, and that in itself may support the reduction of substance use simply because they have more tools. Something that I want y'all to keep in mind when addressing substance use is not just to say, hey, this is the issue, and we're going to have to go forth with stopping this before we do this. More, it's integrated, and there are social aspects of marginalization that are occurring. So if somebody's facing more marginalized identities, you might want to be curious about where they're coming from with it first. And so, for example, significant increase in incarceration of drug crimes has disproportionately targeted Black communities. And that's this one here on the left. This one here on the right is an image of the use of substances, which is 53, 47, 38% versus the incarceration or sentence drug offenders in the Federal Bureau, where it's a lot less folks who are white versus people who are Black or Hispanic. So there's disproportionate, and that's just the point here. So my point here with this is there are systems that are impacting the view of substances. Now, could it be that somebody has more extreme views about, example, I think cannabis is a great example because there are individuals who are incarcerated, and then there are individuals who can buy legal weed, which is for the same substance, essentially. So the conversation then becomes, what is the view of it? Some people really minimize the effects of cannabis use. Some people really exacerbate the use of cannabis use and say there's issues with it that are not real. So bringing in the lived experiences or the disproportionate targeting, you don't want to be judgmental. You don't want to be contributing to this as a clinician, because we're all part of this system, right, of people. So maybe being able to bring this in could be reducing the effects of someone who's minimizing the experience entirely. Um, so yeah, just bringing this in because it's an important fact and it's a reality that specific substances are racialized or associated with specific groups, and then specific communities are targeted.